Welcome. Welcome, folks. Welcome to Justice in Public Health. We're going to get started in a minute. We're letting folks get into the space. Welcome, everyone. So I'm going to go ahead and jump in. Folks will continue to come into the room as they are able to. Good afternoon. My name is Lauren Jones. I use she, her pronouns. I'm the Director of Diversity, Equity, and Inclusion here at the University of Minnesota School of Public Health. Before we begin, I want to acknowledge that the School of Public Health at the University of Minnesota Twin Cities is built within the traditional homelands of the Dakota people. Minnesota comes from the Dakota name for this region, Minnesota Makoche, which loosely translates to the land where the waters reflect the skies. We'll share some concrete resources for supporting our Indigenous relatives in the chat shortly. I also want to point out that closed captioning is available for today's program. You can access that by using the icon in the bottom right corner of your screen. You can also reach out to Sarah Harris, who's providing our tech support today, via the chat to ask questions about accessibility. We'll monitor the chat for questions, as well as share links to our evaluation and information about future Justice and Public Health events. Justice and Public Health series was started in 2021 as part of our commitment to justice and anti-racism. We've been hosting monthly events with local and national experts around topics of public health. The speakers and presentations in the series help to ground us in theory and in practice, as well as complement the classroom learning that our students experience. We also hope that today's discussion is a part of a broader change happening outside of the School of Public Health. If you are interested in staying abreast of other justice and public health events, please be sure to fill out our event evaluation after this and check the box to receive notifications about upcoming events. You may also visit our website at any time. We are planning to record today's event and put it up on our YouTube channel to view it later. Now I will introduce our speaker for today. Dr. Inari Muhammad is a two-time graduate of the University of Minnesota School of Public Health, having attained her MPH in 2019 and her PhD in epidemiology in 2024. Her graduate research focused on assessing vaccine hesitancy and gaps in vaccine coverage among BIPOC Minnesotans. She is currently a research project manager in the Division of Epidemiology and Community Health here at SPH. Inari is passionate about health equity and centering the voices and experiences of marginalized communities in public health research. She lives in Blaine, Minnesota with her husband, daughter, and her cats. Please welcome Dr. Inari Muhammad.
Thank you for that introduction, Lauren, and thank you for having me as part of this series. I'm gonna share my slides. Okay, so I am going to get started. So I will be talking about a topic that is pretty relevant right now, which is vaccine hesitancy among Black Minnesotans. I'll discuss historical causes, contemporary challenges, and potential solutions to this problem. So I will be briefly defining vaccine hesitancy as it pertains to this issue, talking about drivers of vaccine hesitancy among Black Minnesotans, and then, like I said, contemporary challenges and potential solutions. So very briefly, and I'm sure most of the folks listening are pretty familiar with vaccines. But vaccines are a tool that we have to help the body build proteins called antibodies, which are produced by the immune system. Vaccines train our immune system to protect against harmful pathogens such as flu or COVID-19. And we know that vaccines are crucial for individual health, but they're also key to preventing infectious disease outbreaks. Vaccines are one of our most important public health achievements, allowing us to prevent more than 30 diseases. And vaccines are responsible for the elimination of smallpox and the near elimination of polio. They're also responsible for the significantly reduced rates of various other illnesses like measles and diphtheria and tetanus. So, what is vaccine hesitancy? The World Health Organization defines vaccine hesitancy as a delay in acceptance or refusal of vaccines despite availability of vaccination services. Vaccine hesitancy is complex and context specific, varying across time, place, and vaccines. It's certainly not a new phenomenon. It's existed since Edward Jenner developed the first smallpox vaccine in 1796. As you can see, this image from that time, people thought that getting the smallpox vaccine would cause cows to grow from their limbs. Um, but it's now a serious public health challenge, leading to a rise in vaccine preventable diseases that were considered, nearly eliminated from the United States and in other parts of the world. So being anti-vaccine is different from vaccine hesitancy. Those who have an anti-vaccine agenda, either individuals or organizations, are invested in deterring people from accessing some or all vaccines. On the other hand, being vaccine hesitant could be someone just being unsure about a certain vaccine or wanting to delay vaccinations for themselves or for their children, or refusing some and accepting other vaccines. And we have to keep in mind that these folks could potentially change their minds at any point. So this figure, the vaccine hesitancy continuum, shows, most for the vast majority of people, um, they're willing to accept all vaccines that are recommended by their providers. And then we have a smaller group that accept some or delay or refuse some, and then an even smaller group that tend to refuse all vaccines. And then even within these groups, right, there's variations. There's people who refuse but are unsure and so could potentially change their minds. And there's people who accept but aren't sure, still a little bit hesitant, but willing to accept the vaccines. Another way we understand vaccine hesitancy is through the 5 C's model. And so I think when people think about vaccine hesitancy, a lot of times confidence comes into mind, right? People are hesitant because they worry about safety or effectiveness of vaccines and the systems that deliver those vaccines, or maybe don't trust policymakers or governments who are, pushing out those vaccines. Um, but then at the more structural level, we have both convenience and context, right? So, how easy is it to get a vaccine? Does the local pharmacy offer that vaccine? Does a local pharmacy exist in the community anymore? So, if it's not easy to get the vaccine, maybe someone might not even bother, trying to look for it. And then context, so structural factors such as racism, socioeconomic status, is the individual insured? What is their relationship with the healthcare system? If they faced racism and they're less likely to visit their doctor or accept their doctor's recommendation. We also have complacency, which in a lot of ways, I think the success of vaccines has led to complacency, right? People are not seeing polio. I mean, it's been like a couple generations since polio was commonly seen. People are not seeing measles, and so they feel that, well, maybe these diseases are not around anymore. So, what's the point of getting vaccinated? And then finally, we have communication or false and misleading information, which in the era of social media is pretty prevalent. There's a lot of misleading, outright false information perpetuated through social media and politicians, etc. So these five C's kind of work together to um, influence how an individual feels about a certain vaccine and their decision to get vaccinated and not vaccinated. So, vaccine hesitancy is a problem that affects all communities. So, why focus on Black Minnesotans? Well, America's legacy of racism and ongoing systems of oppression shape health disparities today. Black Americans have higher rates of HPV or meningococcal disease, COVID-19, hepatitis B, and other vaccine preventable diseases compared to non Black Americans. Black Americans are also more likely to have worse outcomes once sick. And then in Minnesota, in the United States, but especially Minnesota, Black Americans are a diverse group encompassing African Americans, first generation immigrants from Africa and the Caribbean, and their descendants. This is a great figure from the Star Tribune that shows Black population subgroups in Minnesota based on the 2020 census. So, Black Minnesotans make up 7% of the state's population, according to the last census. And this group grew by 45.2% over the past decade. And that includes large numbers of, African American Minnesotans, Somali Minnesotans, um, Kenyan, Ethiopian, Nigerian, etc. However, Minnesota is known to have some of the worst racial disparities when it comes to education, unemployment, income, and health. So, what does this all mean for vaccine hesitancy? Disaggregating Black Minnesotans provides a clearer understanding of historical and contemporary reasons for vaccine hesitancy. Different communities have varying reasons for being vaccine hesitant, and viewing Black Americans and Black Minnesotans as a singular group masks these differences. Unfortunately, a lot of the literature and the research we have just tends to um, either, assess or just view Black Americans as a singular group. So one issue that is particularly pertinent to our African American community is historical trauma. For African Americans, or what I define as descendants of enslaved Africans, a history of unethical medical experimentation influences perceptions of vaccines. For example, the Tuskegee syphilis study, where researchers pretended to treat Black men who had syphilis when in actuality they withheld treatment in order to study the progression of syphilis. Um, or another example is J. Marion Sims, who operated on enslaved women without anesthesia to improve his fistula repair techniques before he operated on white women, and many, many other examples. So, in a qualitative study that we conducted on Black Minnesotan women, um, when asked about some of the reasons for vaccine hesitancy, African American participants talked about historical trauma. So, one participant said, healthcare has not always been kind to those who are African American or in the minority. A lot of older people, they look back at Tuskegee and different studies that were done against people's wishes and without them knowing, and they really take that to heart. Even a sense they look at stuff that was done, even though it sounds silly, as far back as slavery, where people were forced to do things that they didn't want to do with their bodies. And I think because of that, a lot of them are hesitant. Another participant said, I mean, we're not that far removed from issues like Henrietta Lacks and, sterilization of Black women in prisons and all that stuff. That's what it is. There's a lot of Black community non-trust about vaccinations and things that come from the government. And why wouldn't there be? Been no trust restored to this day. Another large community in Minnesota are East Africans. So for East Africans, pretty big issue has been the MMR vaccine and MMR misinformation. So in this community, beginning in 2010, Andrew Wakefield and other anti-vaxxers targeted the Somali community in Minnesota. spreading misinformation about the MMR vaccine and autism. Um, for context, 1 in 16 Somali Minnesotan children have autism compared to 1 in 53 in the general population. Um, the result was a steep decline in MMR vaccination rates in the community. Um, the herd immunity threshold for measles is 95%. The vaccine is extremely effective, and 99% of people who receive 2 doses will develop immunity to the disease. The measles itself is very infectious and very serious, with a wide range of complications, including hearing loss and pneumonia, encephalitis. Despite how serious measles is, it's been really hard to overcome the fear of autism in the community. Um, Additionally, fears and concerns about the MMR vaccine have also affected perceptions of other vaccines. So, rates of other immunizations in the community have also started to dip. So what does that mean? It means that Minnesota has had some notable measles outbreaks as a result of low MMR coverage, coupled with international travel to measles endemic areas. And almost all cases have been among East African children. So 2017, 2022, and 2024 saw um, pretty large outbreaks with 75, 22, and 70 cases in the state. So this also leads to the accumulation of distrust. So this is another quote from our study. A Somali participant said, "The MMR vaccine has been a headache because people have been linking that to autism. And so because of that mistrust or fears of autism in that vaccine, I feel that kind of slipped into the COVID vaccine as well. Had there not been mistrust with MMR, I feel like our community would have been a lot better." So this participant was basically discussing how um, people were concerned about getting the COVID vaccine for themselves, for their children, because the sort of the fear about of autism has started to spread to other vaccines as well. So, some factors like negative experiences within the healthcare system are common across the Black community. Persistent racism in our healthcare system leads to lower trust of providers. Someone is less likely to get vaccinated or get their kids vaccinated if they don't trust the providers they see or the systems they interact with. So, data indicates that Black Americans' negative experiences with the healthcare system leads to lower medical trust and thus increased vaccine hesitancy. Institutional racism in healthcare translates to limited access to good quality healthcare. And interpersonal racism leads to harmful interactions with providers. And so individuals are less likely to accept provider recommendations. Additionally, another relevant issue is anti-vaccine misinformation. Again, this sort of applies to the general population, but there are some um, misinformation that have specifically targeted the Black community. Um, so, mass media, social media, celebrities, and political rhetoric are all sources of anti vaccine messaging. And this misinformation has targeted childhood vaccines, adolescent vaccines, and seasonal vaccines. So, everything basically. Not only is false information being about the vaccines being spread, for example, vaccines contain microchips, the COVID vaccine is going to kill Black people, the vaccine spreads HIV, really all sorts of things. And some of those um, um, are, pretty frightening. But alternative remedies are also being spread. For example, eating yogurt cures HPV. Um, and videos with false or misleading information receive millions of views on TikTok, Facebook, YouTube, and other platforms. And I've included a couple of examples of um, misinformation that has been spread on social media. Some other quotes from our study. So, one participant of Caribbean descent said, "Case in point, my mother's from Trinidad, and so if you follow hip hop, all that Nicki Minaj, she's Trinidadian, and so when she came out with that whole story about her family member, oh, it was ugly, and um, down there in Trinidad, there's a lot of vaccine hesitancy from stories like that." And then a Congolese participant said a French YouTuber would always come up with like different conspiracies around COVID. So people watch a lot of that back in the Congo and then they'll send them to their family members here. And it definitely affects how people view the COVID vaccine. So, the um, current political environment um, has posed challenges to vaccine hesitancy and vaccine confidence. Um, HHS Secretary Robert F. Kennedy has caused significant harm to our public health infrastructure and continues to perpetuate false information about vaccines and other health issues. So in June, Kennedy removed all 17 members of the uh, Advisory Committee on Immunization Practices and replaced them with several individuals who made false claims about vaccines. So not only are the new members unqualified to sit on the ACIP, but many of them have explicit anti-vaccine agendas. Um, the ACIP is important because they provide vaccine recommendations to the CDC, who then sets up the adult and childhood vaccine schedules for the United States. The ACIP could make it impossible to access the COVID-19 or other vaccines if they wish. So by removing recommendations, they could make it so that insurers don't have to cover certain vaccines. What does that mean for equitable access, right? What does that mean for people who can't afford to pay out of pocket for certain vaccines if they're not covered by insurance? That sort of feeds into, the structural inequities that we're already trying to address in public health. So the ACIP meeting with new members is to be held pretty soon, on the 18th and 19th. And I just read this morning that there's a push for delay to the newborn Hep B vaccine. And, hepatitis B is very serious. There's, again, racial inequities in who is affected. And so, right, this is a concern if there's a shift in newborn vaccine recommendations. Another, issue that I'm sure most people have heard is that Florida eliminated childhood vaccine mandates and aims to ban COVID vaccines. So again, what does that mean for people who are going to have a difficult time accessing vaccines? What does that mean if immunization rates drop in marginalized communities and in the state as a whole? So these are just some of the headlines. I mean, it's just overwhelming if you Google anything related to vaccines or RFK or the federal government. There's just tons and tons of headlines, and it's all pretty concerning news. So, where do we go from here? What we know works. So, we know that partnering with community based organizations to provide education and address concerns works. Strong provider recommendations work. So, evidence shows that high quality provider recommendations are associated with parental acceptance of childhood and adolescent vaccinations. Um, Addressing vaccine misinformation at multiple levels. So, during clinic visits, on social media, and through mass media. Providing vaccinations at community sites, mosques, churches, and community centers. So, a few years ago, I was part of the Seaward Vaccine Equity Project, where we partnered with local clinics, unions, and mosques to provide COVID-19 vaccinations at mosques in the Seaward neighborhood. We were working to address barriers by contacting people in person. We partnered with the unions to go walk through the U of M buildings, where the housekeeping or the environmental services staff was working, and we talked to each one of them, or as many of them as we could reach, and told them, hey, there's like a vaccine clinic that's happening. Do you want to sign up? And we're able to answer questions. So we're really meeting people where they're at. Um, we provided transportation for people who didn't know how to drive or couldn't take public transportation. We provided interpreters, and it was a very successful effort vaccinating dozens of people at each clinic. And I think it's a really great example of meeting people where they're at and bringing the vaccine to people in a place that feel safe and comfortable. And making sure the face of these efforts are already members of the community, right? Um, so I think it's an example or of a format of providing vaccinations that um, could work well with not just the COVID vaccine, but other vaccines as well. And there's an article about it that uh, I recommend. So, what do we need more of? Money. So, private and public funding for vaccine research. We need to counter funding cuts from NIH. So, a lot of researchers who were studying vaccine hesitancy got notices saying it's the policy of the NIH not to prioritize research activities that focuses gaining scientific knowledge on why individuals are hesitant to be vaccinated and or explore ways to improve vaccine interest and commitment. So, right, there's like a two-pronged approach to dismantling vaccine confidence, cutting funding for research that aims to address vaccine hesitancy, at the same time, feeding into um, fears and concerns about the vaccine and trying to limit and reduce access. We need more Black researchers to conduct vaccine research within Black communities. So the study that I cited was one that where I conducted qualitative interviews with 60 Black women in the Twin Cities, and there was people were really receptive. I know there's sometimes um, this idea that Black people don't want to participate in research or they're hesitant, interacting with academic institutions, but people were really receptive to being interviewed and having an opportunity to express their thoughts and their concerns about vaccinations. And I think there's a lot of room to do more of that work. And I think it's needed. And we need more representative outreach that includes Black people who are already members of their local community. Um, we also need culturally appropriate public health communication, the right language, right dialect, the right medium. We can print a million flyers, but if there's a community that is not literate, that's not helpful. Um, And then finally, healthcare and public health institutions must build trust with Black communities and address systemic and interpersonal racism. And this includes advocating for more Black healthcare providers. Um, yeah, so I'm happy to take any questions. Oh, okay, so what do you think is the motivation of those who spread lies about vaccines? Um, I would say a few things. People want fame. I mean, it's been over 20 years since Andrew Wakefield published his false study, and we're still talking about Andrew Wakefield. Um, there are groups that have, that want financial gain from their misinformation. Um, yeah, and there's been sort of a rise of anti-science or anti-intellectualism as well. I feel that affects people's perceptions of vaccines. What was it like going up to workers around the UMN campus to ask about the vaccine clinic? I think it went really, it was, I think, much appreciated by the workers. We were talking to them face to face. They like that. Being able to ask their questions, being able to say, oh, some people were like, oh, I have like a cousin who needs the vaccine but can't drive. And then we were able to arrange transportation for them. So I think it made the vaccine clinic more accessible. And it was more effective in some ways than social media. Uh, do you see a role of gender in anti-vaxxism? I find it interesting that they're all men, but women are the ones who end up taking care of the ill. Yeah, um, I I think gender does play a role. Um, in a couple ways, right? Women are the ones making decisions for their children, most times making healthcare decisions for their children. So, in a lot of ways, their opinion of vaccines matter more. But also, a lot of the people who push anti-vaccine rhetoric happen to be men, unfortunately. Um, and yeah, I don't know. It's frustrating. Um, have you seen any evidence of a concerted effort to fund vaccine misinformation? Mm, I feel like I've seen a concerted effort to defund work to address vaccine misinformation. Um, I think, you know, one of the ways to combat misinformation is to have like rigorous scientific knowledge to address myths and misconceptions. And by defunding that, it's easier for anti vaxxers to spread whatever they want without pushback. So, yeah, by cutting funding for vaccine hesitancy research, is it, it cuts down anyone who can challenge um, anti-vaccine rhetoric. What forms of education have you seen work best in non-Caucasian or non-English as primary language recipients outside of pamphlets? I think YouTube videos, Facebook shorts, um, so things that are, people can just click and watch and click and listen to, I think works best in um, non-English speaking communities, just because, we can't guarantee that everybody understands and reads or writes in English. So yeah, video. I mean, a lot of people are already on TikTok and Facebook, so putting videos on there would, I think, be helpful. As the new Americans from these birth cohorts become adults, do you think the tide will change among the group? I don't know. That's a hard question. If, growing up your whole life you hear that the MMR vaccine causes autism, it could be hard to um, move past that fear. So I think we'll see as these young people start college, what happens to their immunization rates. And there's things you have to get in order to go to college. So yeah, we'll see what happens. At a recent back to school vaccination event, a parent indicated that his children would not be receiving the MMR vaccine due to a pork derivative. Have you encountered this perspective in serving the community? No, I haven't heard this in my own research. Um, I think for the most part, what was had been echoed is just the fears of the vaccine and autism. Um, and I guess I'm not sure about like non-pork containing MMR vaccine offerings. That's not really my area of expertise, but this question by the parent would make for a really good research study to see if this is a prevalent thought in, I guess, the East African community. What is the importance of vaccination that I can share with the people in my community? Um, I think to emphasize how dangerous infectious diseases are, especially for children. Um, I think I think there needs to be better education about how debilitating the short-term and long-term consequences of infectious diseases are. And um, parents, of course, want the best for their children, want their children to be healthy. So maybe emphasizing that to the community. I might have missed it, but how do these trends of declining MMR vaccine uptake among Somali populations compared to other Black populations in Minnesota? This is a great question and something that we did look at in some of our research. Um, I can link a couple of papers that we worked on this topic, or I can put it in the chat. But yes, the Ethiopian community as well has seen a decline in MMR vaccine. The Somali and Ethiopian communities tend to be kind of close, so I think the fears from one community sort of spread to another. But the MMR vaccination rate in the Ethiopian among Ethiopian children is down to like 60% or so. Um, and then other non-Black populations, I think for the state as a whole, coverage is lower than 95% for MMR, but not declined the way it has in the East African community. Is there any study that assesses autism rates in the Somali community following the mass community withdrawal from the MMR vaccine? Um, I haven't seen any, but from what I know, I think the autism rates have remained steady, um, same before and after um, the sort of decline in coverage rates. Um, with the increase of AI and health influencers, elders in the communities are unable to differentiate what's credible and what's misinformation. Moving forward, what approaches can we take to address both cultural concerns and digital misinformation in ways that build trust? I think by having members of the community, so people that elders might recognize, be a part of that communication, maybe make it more trustworthy. I know even for me, sometimes it's hard to tell what's real and what's AI. So I think that needs more, um, if not digital, but in-person communication with elders and with other people in the community in order to answer questions and address some of the misinformation that they're seeing online.
Yeah, thank you, Dr. Muhammad. We're so excited to have had you. Can you talk a little bit about the work that you're doing today and what we might look forward to? And then second question would be, how can people reach out to you?
Yeah, so I'm currently working on some projects focused on structural racism in the healthcare system. And I yeah, I can be reached at my UMN email. I'll just put it in the chat. And yeah, and like I mentioned, there's a couple of publications that we have on some of these issues that I think would be helpful for anyone interested in understanding more about vaccine decision making and MMR rates in diverse communities in Minnesota.
So we'll give just like 30 seconds for any additional questions. I know sometimes it takes people a minute to type, but I will mention that we have an evaluation, so we always want to check in and see how we're doing as an organization, as an office. And so if you could, before you leave, click on that link to fill out the evaluation. We'll also share that with Dr. Muhammad to make sure that she continues to grow and learn. We have a question here.
Do you think Gen Z is more aware of successful studies of vaccines than Gen Alpha? Um, I think I think Gen Z is also I think Gen Z on social media doesn't seem like they're more aware of vaccine studies. I think for both generations, it really matters where they look. If they're open to or willing to do research and look at trusted sources versus social media, TikTok, Facebook. I really think, yeah, the source of information really matters more than the generation.
Such good questions. So we do want to mention we have another Justin Public Health event next month. We'll talking about the reproductive justice denied, the structural violence of recent federal health care cuts. Sorry about that. So we'll go ahead and end there. Thank you all for coming. We appreciate you. Thank you, Dr. Muhammad, for sharing with us once again. And we hope to see you at a future Justice in Public Health event and maybe later today. Take care.